And we're grateful to you that for Sadiq International Virtual University, you people join us regularly in our programs, webinars, short courses, lectures, etc., etc. Today we have a very, very dear friend, Professor John Sanders from Edge Hill University, and he's going to talk about a very fascinating subject like teaching for transfer of learning. Now, this is something new. I'm not myself a genuine educator, but I'm very keen to learn from experts from John Sanders, people like John Sanders and others. So I don't want to interfere in your learning process without delaying any further. We already delayed by 5 minutes. Let me hand you over to Professor John Sanders from Edge Hill University, UK. Over to you, John.
Okay then, thank you very much, Abby, for inviting me. And it's great to have an audience who are interested in this topic. So welcome, and it's a great privilege to talk to everybody across the world. I've always considered that medical education is one of those areas of medicine that transcends cultures, and it's a great privilege to share and to collaborate with colleagues. So my topic today is teaching for transfer of learning, because increasingly I think this is a major concern for us. And the challenge of transfer of learning is that we spend thousands of hours training our doctors as students, as trainees, as residents. We might try lectures, we might try working with patients, we might try with simulations. But the big proof of what we call proof of the pudding is whether that doctor can actually transfer the learning which they've had in the classroom or in another context to the unique situation in which they are faced. And one of the classic models of the evaluation of training, Kirkpatrick's model, looks at what an individual does. They acquire learning, they begin to change their behaviours, but ultimately it is their clinical performance. How do they perform with the complexity of cases that they meet? And here's some typical quotations. One of them was a recent scoping review that we did with one of my PhD students who's a doctor. And this is really what reignited my interest in this topic. Because what we were looking at is how you can actually provide training to under and postgraduates in medicine to manage the acutely unwell patient. And as it says there, many of the studies generally fail to capitalize on its potential for transfer to practice. And if we start looking at other areas, there is scant evidence from randomized controlled trials to suggest a significant effect on patient outcomes. Undoubtedly, it does work, but not for every instance. So how can we begin to understand this in a much better way? And this is where we actually need an understanding of the educational principles if we are to maximize the learning for transfer. So transfer of learning occurs when we apply our past learning to new situations that may be similar or different. And one of the major authors, Richard Hassel, talks about, it's often an assumption that transfer will take care of itself. In other words, we expect that the way that we teach will actually help people to transfer their learning. But all the research suggests that unless we are much more purposeful in how we do this teaching, that in the end, transfer of learning cannot be guaranteed. And Shunk, who's one of the great gurus of educational theories, So that transfer lies at the heart of our system of education. Why are we bothering to train people if they can't, in fact, transfer their knowledge, skills, and values and their behaviours to situations in the future? So let's look at how we can gain a greater understanding of the transfer of learning. One of the most influential pieces of information, which is based on extensive research, and they came up with a conceptual model, was by Salomon and Perkins. And what they said, that there are two dimensions to transfer. One is the timing of when you transfer, and one is the context, and they're both interrelated. So for transfer, it can be pretty close to when the training event occurred. So if you measure somebody's, say, lumbar puncture skills after a simulation, if they do it within maybe 10 minutes or the next day, they may be able to transfer that skill to doing it again. And this is called near transfer. But you do that 6 months later, far transfer. The research suggests that for something like lumbar puncture, that the learner may be unable to perform all the correct steps. And context is important as well, because things which are very familiar and they've come across thousands of times before are going to be much easier to transfer than unfamiliar ones, which are completely different. And at the heart of transfer of learning is what's called the similarity principle. One of the great psychologists over 150 years ago, called Thorndike, came up with this idea that the way that we transfer our learning is by looking for identical elements between how we've learned something in one situation to how we can apply it in a different situation. So we're looking for similarities. So the more similar something is to what you've learnt it in, the greater the chance that you can transfer it. Now, Salomon and Perkins talked about two approaches to developing transfer of learning based on the similarity principle. The first is what they call for low road. It is the low road approach. So what happens there is that when someone is faced with a particular situation, they search for previous knowledge. What do they know about it? What is similar or different to this situation? And it's automatized by repeated practice. So something like cardiopulmonary resuscitation is relatively simple. If it's just the chest compressions at whatever the current recommendation is, if you learn that and repeatedly try it, have several opportunities, the chances are you are going to be able to apply it in different situations, but only if they are simple and similar. High road transfer of learning, you can't apply repeated practice to the same extent. What you need to have is a good conceptual understanding. So for low road, where you can rely on just repeated rote learning, repeated opportunities, it's great for near transfer. It's great for very familiar ones. But as soon as you get transfer in the future, 6 months, in unfamiliar and different cases and situations, you need to have developed conceptual understanding. So what we're going to focus on now is about how do you actually develop conceptual understanding and conceptual knowledge. And that comes down to some basics of about how we actually go about the process of learning. Whatever we learn has to get into our memory. And then it has to be recalled from the memory at the time of the situation when you are applying it. And that will depend at the time from when you initially learnt it and in a particular context. But it's pretty complex because the effectiveness of transfer is dependent upon the quality of existing prior knowledge. If you haven't acquired conceptual understanding, you're going to find it difficult to transfer it to novel and different situations, especially long after the initial learning event. They need to be able to build on what they already know to transfer their learning. But also, the learner needs to possess the dispositions, the knowledge, the strategies, and the processing skills which are relevant to the transfer task. And they also need to have opportunities for transfer to different situations. So if we're going to try and break down this complexity, this particular model here, which was by Baldwin and Ford, is actually quite useful because it looks at three important factors. The first is the learner. Learners need to develop what is known as declarative knowledge. Declarative knowledge is the facts that you and I acquire about a particular topic. So maybe it's about cardiopulmonary resuscitation. We need to know certain facts to enable us to be able to effectively do it. We need to know how many compressions we should be doing, the rate of the compressions. But importantly, these facts for the more complicated aspects, such as how to diagnose diabetes or renal failure, or the differential diagnosis of hemolytic anemia, we need to have good conceptual understanding. We also need to have procedural knowledge. Procedural knowledge is how to do something. Declarative knowledge is knowing about something. Procedural knowledge is knowing how to do it. So for something like CPR, you need to know certain strategies. It's not just actually, this is how many compressions you need to do. This is the rate. You need to know how to actually do the compression. So it actually is working deep enough. And over time, what you get is the integration of declarative and procedural knowledge through automation by repeated practice. So this is how a learner begins to acquire it. So for something like clinical diagnostic decision making, for something like diagnosing renal failure across different people, you need to have the basic core knowledge, but you also need the skills on clinical reasoning, like assessing the case, applying it, thinking of the probabilities, aspects like that. But also the learner needs to have the appropriate motivation. They need to think that this is developmental, but they also need to develop a transfer mindset, that what I am learning can be useful in the future and will be useful. So if we're going to offer training, The first thing we need to do is to develop the learner's motivation for transfer, and that's that engagement. And we're going to talk about how we can do that in a moment. But they also need some cognitive skills in training, and we need to develop that. We need to be able to get it into their memory in the first place, and then get it out of their memory. And getting it into their memory isn't just teaching facts, it's also developing conceptual knowledge. So if we wanted to develop the motivation of the learner, we need to ensure that the learners can understand why they are learning something at a particular moment in time. So if you're going to be giving a talk about something, always try and make it relevant, saying in 5 years' time, in the next week, you will be meeting patients like this. This is why you need to learn it. So they can see the immediate relevance of it. And getting it into the brain requires conceptual understanding. So conceptual understanding isn't remembering each of those different trees at the top, because they're isolated. The conceptual understanding is the fact that a tree has a green top, essentially, and a brown stem. Because until you begin to recognize that, if you think it looks different, you're not going to be able to recognize individual trees anyhow. So the conceptual understanding is that there is some sort of core information which is essential, and then each tree is slightly different or slightly similar to that original conceptual understanding. So how do we develop this conceptual understanding? The first thing we need in the brain is organization and elaboration. Before we were talking earlier, this presentation, I was talking to Professor Shabi about neuroscience. And neuroscience are these networks that we have inside the brain. And this is what we need to be able to build up. At a simple level, we tend to call these schema or mental models of things. So the organization isn't just learning simple, isolated facts, but understanding the differential between these facts. So, for example, I always remember a student when I was teaching many, many years ago. I was a junior doctor and teaching on the hospital ward, and I can still see it now. And what happened is that this patient had got aortic valve disease. The standard textbook then was Davidson's textbook of medicine, and it would just have a list of various conditions. And the student examined the patient and correctly identified aortic valve disease. And I said to the student, what do you think the commonest cause is for this? And the student said, syphilis. And the reason why is that if you went to Davidson's textbook, because we talked about this afterwards, in that list of aortic valve disease in an elderly person, at the top of the list was aortic valve disease related to atherosclerosis. Then it started going down to rheumatic heart disease. Then it went down to a few others, which I can't remember. And then eventually it was syphilis. But it didn't talk about how common they were or the features. So the student was able to write down these facts and learn them parrot fashion, but he couldn't organize them into ones which were common, but also importantly, the elaboration of them. So this is about what are the distinguishing features between atherosclerotic, rheumatic, and syphilitic. And we can do that by encouraging students to not just learn parrot fashion the lecture notes or the textbooks, but to make their own notes and annotate them, build concept maps, build it to their experiences, so that as they are seeing different patients, they can begin to realize that there are similarities and differences. And this is where you develop this rich conceptual understanding that at the core of it is aortic valve disease, but there are different and similar and different types of aortic valve disease and what those distinguishing features are. Because then the way that we learn is that once we've got this information in our brain, we then need to recall it, what's called retrieval practice, through testing. You can explain, or getting students to explain or teach it to others, because then they begin to reinforce what they know, what they don't know, what the differences are, what the similarities are, which then builds again into their knowledge structures, their schema, to get it into their memory. And fundamentally, transfer requires some conceptual understanding. What is similar or different between aspects of a core concept? So there are core concepts like that green top and the brown stem, but then the conceptual understanding is that there are differences between the various trees and the similarities. And this has major implications for learning, teaching, and testing. Also, going back to that original diagram, students, if they want to transfer information, need some support. And the research suggests that there needs to be a sense of belongingness. They need to feel safe to experiment, but they also need repeated opportunities to recall this information, get feedback, and then put it into practice. So repeated opportunities by seeing large amounts of different patients with different conditions is absolutely essential. So at a practical level, how can we actually teach for transfer of learning? This, although it's an old quotation, I think is really apt. If we want transfer, we need to teach in ways that actually enhance the probabilities of transfer. And fundamentally, it's not about teaching for now. It's about teaching for the future. And for me, having this mindset is essential for educators. So how can we do it? So what do students need to be able to do? What's the student perspective? Basically, students need to be able to build connections between new and prior knowledge. And we're going to talk in a moment about how we can enable that. Students need repeated opportunities to do different tasks and to be problem solving. Students need to be able to begin to analyze at the distinct parts of something and work out how these parts relate to each other, what is similar or what is not similar. But they also need to be able to check that their assumptions of whether something is similar or different are correct. So how can we practically do this as a teacher? One of the ways we can say is that when we're teaching, whether it's giving information or teaching skills, is to say to students, how can you use this information in the future? I remember as a student many years ago learning the Krebs cycle when I was a student in Sheffield. Sir Hans Krebs had worked there before he went to Cambridge, or was it Oxford? I can't remember which one he went to subsequently. But at that time, he'd worked in Sheffield, and we had to learn the Krebs cycle. We had a multiple choice paper, which we had to pass at the end of the first year to progress to the second year. I had no idea why I was learning the Krebs cycle. All the intricate parts of it. So an important aspect is that the learner needs to be motivated to learn it and to read about it, because this is the job that they are going to be doing in a few years' time. So one way of doing this is to give cases and to say to people, this is what you will be dealing with in 5 years' time. This is a typical scenario that you will be dealing with. When they're faced with this situation, you can say to them, have you seen this before? When they're dealing with a particular case, or you're asking them to do, say, a practical procedure. What does it remind you of? Well, that's what I did before. What does it seem similar to? And what do you already know about it? So they then can put it into practice and see whether, in fact, it works or not. If it doesn't, they then need to make changes. One of the roles of having the teacher is that we can provide what's known as bridging. This is essential for high road transfer. What we do is, if we know what the learners already know, a knowledge base, we can then create simulations or look at clinical cases that we have available so that they are similar or different to what they already know, but in some way it is different because it's in a different context. And what we need to be able to do is to enable the learners to see and make connections between what they've known before and what the present situation is. And the main approach to teaching is to be pointing out similarities between the present situation, this particular patient, and what they've done before, to teach about underlying principles, not just the facts. So this is about the conceptual understanding that you and I have as experts in the field, and to the relationships between what is known and what they don't know. And this can be through the importance of what's known as analogical thinking. So the teacher tries to elicit the underlying principles of something. And again, this is for high road transfer. How is something similar to something else? And how is it different? Just asking these questions, this is the work on teaching mathematics, is that it actually helps the learner to develop an understanding, but also it helps the learner to be able to transfer this information in the future. So what's the teacher perspective overall? Well, we need to have a mindset that we're not just going to give basic facts. We're going to teach for transfer. So that's helping to think about the future, helping learners to understand why they're learning something, but also every opportunity that we have when we meet the student is to be asking these questions. What is similar or different about? What do you know about this already? What is similar or different to what you've read before? Why is it similar? Why is it different? And that helps the students to be able to more accurately and more fluently retrieve information. But they also need, as it puts there, to be getting feedback on whether they were correct or not. We also need to have a wide variety of learning conditions. If they can learn it in different ways, asking questions, quizzes, the more they do it, the better. But these types of questions need to be conceptual, such as solving cases, problem solving, not just simple recall of information. And they also need to have assessments. And these can be informal or formal, the way that you ask, or they can be formal assessments. But these need to move beyond just simple facts. So instead of asking simple questions like, the dose of penicillin, it's about, if you had a choice of doses of penicillin, which one would you pick, rather than asking for and looking for just one specific approach, one specific fact. So overall, we can improve the transfer of learning, but we need to be able to teach it. We need to be able to teach for transfer. And one of the difficulties with a lot of the simulations is that they do have, if you measure in the short term, it does show a benefit. The more simple procedures have longer term transfer, far transfer, and across more complex situations. But that's not what we always want. We want our learners to be able to apply it to the complexity of life at any problem that they have. And at the moment, simulation unfortunately does not provide it. All the studies suggest that it can fall foul. And what I would suggest is that the reason why we fall foul is because we are not actually teaching for the transfer. So what we need to do is to be teaching, getting so that the learners are aware of why they're learning things. Giving some anecdotes helps, helping them to be thinking through situations, what they would do, what they wouldn't do, how is it similar, how is it different. There is no easy answer, but I believe that if we use some of these principles, that we can actually improve the transfer. So I hope that you found it useful, and I'd be delighted to answer any questions. Thank you.
Thank you, John. Excellent. And I can see Azim Mirzazadeh is here. He was the original moderator, and I took up the initial work just to introduce you. Azim, are you there? Azim Mirzazadeh? Professor Mirzazadeh. Can you unmute yourself?
Yes, I am.
Good. Welcome. Good to see you. Why didn't you come and see us?
Hello, Azim.
You were in Glasgow. You met John, but you didn't meet me.
Yes. Good afternoon, good morning, good evening, everybody.
I'm the original Scot. I belong to Edinburgh.
Great.
Yeah. So over to you for question
sorry for delayed arrival, and thank you for inviting me, and thank you, John, for this thoughtful presentation about one of the most important issues for all the teachers, about the transfer of learning. And as he mentioned, it's a major challenge for all of us as teachers, how we could improve the transfer of learning for our trainees. I would like to ask the audiences and the participants to provide any questions or comments. The first one, John, thank you so much.
Yeah.
But the first one is, if you find that there is a shortage of this knowledge transfer, could there be a way to fix it, or would you need to revisit all levels again? This is the first question from TMS.
Sure. I'm not quite sure about revisiting all the levels, what all the levels mean. I think the value of having models like the Baldwin model is that it helps you to think about that there may be some issues related to the learner. There may be some about our instructional technique, and there may be some about the environment. So if the students are not beginning to transfer, and again, I think we need to be thinking about specific situations, because essentially what we're doing is transferring our conceptual knowledge, which is that Baldwin learner instructional approach and environment, to different situations. So actually we're transferring it. The value of having a model is it helps us to deconstruct and make sense of why something hasn't worked. So if we try and bake a cake without having a recipe, it's difficult to know whether it's been success. If it's not successful, you need to begin to analyze all the aspects of that recipe. And for me, as an educationalist, having what I call these thinking frameworks is really, really useful. I recently wrote an AMY reflective practice guide, and not reflection, but reflective practice for educators. One of the areas is about having and developing these structured thinking frameworks, so you can actually begin to deconstruct why things are going wrong. It's just like what a plumber does, or an electrician, or when you take your car in for a service. They go through this like fault finding process. So this is in other words, a fault finding process. So is it something about the learner? Do they actually understand why they are learning this and the value of learning it? And you can ask that. So, I can see that you haven't learned this particularly well, from the past. Can you see any importance why this is important, knowing this? So it's about trying to find out why it's important. Does the student understand the importance of learning this information? And then what do they know about it? It may be that they haven't got some core information. So you need to begin to think about, am I expecting too much from them for their stage of training? Have they already covered that information? That's at a simple level. But if you were working, say, with a trainee, I used to work in family medicine, and I used to have individual trainees working with me. If they were beginning to struggle, I used to try and get them to complete a short multiple choice quiz on the topic. At that time, we didn't have, it wasn't highly computerized, but there were quite a lot of tests available in books, and we had them in our practice library. So if it was something related to, say, cardiology, I would see whether they actually had the core knowledge. Because if they haven't got the core knowledge, they've actually got nothing to build on. So they might need to revisit the core facts. But they also need to begin to make sense of individual patients by building up their conceptual knowledge. So the conceptual knowledge is about how is one thing similar and not similar to what they've already known. So, for example, the diagnosis of something is based on a syndrome, is a collection of symptoms and signs, but they vary slightly from one patient to another. But overall, there is a similarity. So the overall concept of cardiac failure will have certain key features, but it will vary some of those features to varying extents, such as, the JBP, the extent of that compared with the extent of peripheral edema, compared with having a triple rhythm or not a triple rhythm. So things like that you need to be building on. So if it's dermatology, how does, psoriasis look slightly different, both on its sites and not sites? So they've got that. The next thing is to actually look at how we're actually teaching it. So are we helping individuals to think about what is similar, what is different, what do you know already about it? How similar or different is this to what you already know? What else do you need to find out? But they also need the appropriate environment. They need repeated opportunities to be practicing this. And that becomes increasingly difficult. So if it's clinical reasoning, it's no good relying just on seeing the occasional patient on a ward. They need to be seeing lots of patients. At the moment, many students seem to be reluctant for all sorts of reasons, and because of the workload, students find it really difficult to often see lots of patients on the ward, or they don't see the benefit of seeing them. But what they need to see are lots of patients with varying differences. So they begin to realize that when you're palpating the abdomen, there's going to be different feelings. So, say for feeling an enlarged liver, between somebody who's very thin, somebody who's obese, somebody who's moving around, somebody who's not quite laying flat. All these things, they need to have lots of experience of doing. Now, if they can't get that, and with different presentations, if we can't do that, the alternative is to do it through simulation. And the other alternative is to use virtual patients or paper-based reasoning tasks. So they're getting lots of experience. And it's not about doing lots of multiple choice papers, which are just basic facts. They need to have the ones which are based on clinical cases. So does that, I hope that answers what a colleague was asking.
Yes, I hope so, and I feel that you have covered. The other question is about the from Bahauddin Hadi.
Yeah.
He mentioned that what are the main gaps for transfer of teaching and learning in either direction? It seems about teaching and learning in either directions, and do you believe the AI will narrow these gaps soon? The role of AI,
right,
and the problem for transfer.
Number one, I think the great value of AI is that it can analyze how individuals are applying information very rapidly to identify whether they've got particular gaps. So, for example, the work of Martin Pusick with residents learning how to interpret radiographs. If you've got a large number, a panel of pictures, as somebody is doing it, working through this panel, you can begin to see whether they are interpreting them appropriately or not. You can have adaptive testing so that actually, if they're struggling with one little bit, say that it's the rib, say they've got a rib abnormality, they can then see further rib abnormalities, but subtle changes. So they begin to realize what is normal, not normal, what could be abnormal. So you're presenting them with that. And some students become very good at it and some don't. So you can develop these learning curves. the majority of people are not going to have a major problem. But about 10% will struggle. And if they've got this 10%, this is the difficulty, what you need to be able to pick up. So repeated testing, recall, what we talked about, the testing effect, helps us to target feedback in a more effective way. This can be done automatically with AI, but also we can get the information as well, which again is AI. The other thing that AI can do is to identify very quickly, as they're going through cases, what they're doing and what they're not doing. So for example, on virtual patients, which are designed for clinical reasoning, the AI can again pose questions. These are prompts. Is it similar or different? How is this similar or different between these two cases? So you can actually start building that up. So I hope that answers it. I think AI is such a large area. Essentially what AI can do is to get a much finer grained understanding of what learners are doing and not doing. That's through what we call learning analytics. But also it can provide numerous scenarios, numerous cases very quickly. So you can build up this really rich, deep picture. And that's, so you've got basically a learning and testing system, which they're both intertwined. And AI can do that rapidly and at scale.
Azim, can I just comment one thing before we move on?
Yes, sure.
John, is it different to what the Platonic forms and priori knowledge and Immanuel Kant's priori and posteriori knowledge that you mentioned about the various concepts of learning and then experiential learning? Or, as I was talking to you earlier on about the phenomenology, is it something different to what you're just talking about? Priori knowledge is where you're born with something that, like apple is a fruit. Posteriori knowledge, apple is sweet or bitter. Is that something that I'm gaining from your lecture right now or something different? Thank you.
Yes, I think these are based on neural networks. I mean, undoubtedly, when you're learning a language or learning some things, there's been a big debate in philosophy whether we already have established neural pathways for our memory at the time when we are born. There is some suggestion that young babies are highly receptive to learning. So if they were doing that, they must have some prior understanding before they've been exposed to something. So they've almost like got a blueprint there to build on. Whether that's true or not, I don't know. I think there's huge debate about it. But subsequently, what you're talking about is that as we develop normally, we begin to know, our parents tell us this is an apple. So we begin to know that this is an apple. Then with time, we begin to realize that that some apples are sweet, some are bitter, that some apples are green, some apples are red. We begin to realize this is a tree. And if you look at children's books, like Dick Brunner's books, for example, these very simple books aimed at very young children, they have very stylized pictures of, a face, a ball, a car. And that's because what the child recognizes is that this is a concept. This is what a car is. This is what an apple is. This is what a balloon is. This is what a house is. And with time and experiences as a teacher and as a parent, children begin to recognize the different types of houses and the different components. This is a really, really complex area. So it is developmental. Now, just like very young children learn, we have got to do the same job in medicine. We've got to help them to develop that blueprint in their mind and help them to begin to see what is different and what is not different. Because when they face something very different in the future, they have to manage it. So
Thank you so much.
Does that answer it?
Yes, absolutely perfect.
Yeah.
Over to you, Azim.
Yeah.
Yes, thank you. Thank you. We have a few questions and we need more time to cover the questions. One of the questions from Mr. Bahauddin Hadi is about the challenges of undergraduate students in basic science laboratories. And do you have any comments based on the transfer of learning topics that you have mentioned today to help our colleagues in basic science departments for basic science labs for undergraduate medical students?
Yeah. Again, I think there are two big assets. One is getting the students to understand why they are learning this information in the first place. So they need to be able to understand why they are learning these aspects for basic science. So just learning anatomy backwards, rote learning it, is not going to be useful to it. They need to understand why they're going to be needing it in the future. So understanding, some biochemistry. So I always remember I was visiting, and I won't say which country. I was invited to sit in a lecture, and during the lecture, it's been given by this professor, and it was this incredibly in-depth discussion of the biochemistry of the thyroid gland, about how the thyroid hormones and the globulins were all being made. And during it, the professor kept asking students for particular bits of information. And at the end of it, I thought, why does anybody actually need to know this at this great detail? There was no way that, and I was a clinician, there was no way I understood why I would want to learn that. So making it relevant is really important. If it's not relevant, why are we teaching it? If it is relevant, we need to be shown. It might not be immediately relevant, but this is why you need to understand it in the long term. So that's one aspect, is the motivation. The next thing is that we need to be teaching conceptual understanding. So what is more important? Knowing all the minute stages of the Krebs cycle, or understanding that the reason for the Krebs cycle, and I may be totally wrong here, so don't believe anything I'm saying because I've forgotten all the biochemistry. But for me, it's something about the key aspects is about phosphorylation and about, I think it's some way of energy transfer. So that's what needs to get across to the student, that this is why we're doing it, and these are the steps that do that. So unless they understand that, and that maybe shows that I've never understood the conceptual understanding of the Krebs cycle in great detail. So it's the same as if we're looking at anatomy. It's a structure and function. So how, what I can see in anatomy, there's only a certain number of ways in which structure informs function. There might be 20. And that each individual organ actually has the same pattern. So it's beginning to understand that. Of course, you need the facts as well, but they need to have a conceptual understanding. So when you are teaching it, you need to make sure that you're getting that information over to the student. What you then need to be able to do is to, when you assess them, is to have assessments. Now you can have assessments at the end of the session during a session or long after the session in a more formal assessment, but informal. So, for example, my youngest daughter is teaches maths as a special subject in schools. And if she's teaching a particular maths problem, again, she wants to know whether the students are actually having the conceptual knowledge at a moment. So what she does is she gets them to write the answer down and how they've worked it out, and they show it on a whiteboard. So when she looks around her class, she can see which children seem to be understanding it or not. Now, anybody who's teaching a subject, who's the expert, is likely to have conceptual understanding. So asking questions, getting students, knowing whether what you explained is working or not, is really important. The educational triangle is that we have an aim, we have methods, and we have assessment. Without assessment, how can learners know whether they've learned it? And how can we provide feedback if we don't know whether they've got it right or wrong? The problem is with assessment, we've all become obsessed with assessment as a formal exam. But actually, teachers are doing it constantly as they are teaching, moment by moment, every 5 minutes, every 15 minutes, at the end of the session. So we need to be developing ways of checking understanding of the group before we move on. So hopefully that helps our colleagues to be thinking about how can they teach for transfer using basic sciences.
Yes, thank you. Thank you so much. Do you have my voice?
Yes, I can hear you, thank you.
Yes. We have at least 2 other questions.
Yes, that's okay.
One of the questions is about, could you provide any framework for bridging knowledge transfer gaps?
Well, the framework was what hopefully, that I said before, it's about, you need to be able to analyze, is it a problem or a difficulty that the learner residing in the learner? Is it something about the way that they're motivated, that they're interested, that they know what it's about? Have they got basic knowledge? Have they got conceptual knowledge? Have they got opportunity? So that's number one. Is it something residing in the learner? The next is, have we got the right instructional approach? Are we teaching for conceptual understanding? And teaching includes assessment, because constantly we learn by learning, recalling it, because that's how we build up these schema or mental networks, because then we can have a really rich neural network. And finally, do they have repeated opportunities to be putting this information into practice, which is the environment? So that, for me, is the framework that we need to go through. There isn't a right way or wrong way. It might be all of them. It might only be one aspect. And it's about analysing that situation that you're thinking about to the extent to which this framework of the learner, the instructional approach, and the environment are interacting. So I hope that answers Dr. Sivans.
Yes, good. Thank you. Thank you. And you mentioned about these 3 aspects in the model that you have presented.
Yes.
About the learner, about the instruction, and also about the environment. And another question from my great friend, Dr. Zaharzadeh, about how you evaluate the role of reflection in transfer of learning process.
Right. Well, for me, reflection. Sorry. Yeah, absolutely. I noticed a colleague had also put about metacognition earlier, the importance of metacognition. Metacognition, okay, we can, there's philosophical differences, but essentially there's a different, metacognition is the process of thinking about thinking. Meta, above cognition. So it's above thinking. It's our control system. So we're monitoring constantly. Do we understand something? Is it going right or wrong? If it's not going right, do we need to make any changes? So that is what reflection is. So reflection is part of that recall process. So gets into the brain. We then have to recall it and apply it to practice. Then the learner has to reflect on it. Did it work? Was it correct? How they've applied that information. If it wasn't correct, why wasn't it correct? So it's about using the similarity principle and that analogical thinking. So if it wasn't right, it's questions like, well, how similar or dissimilar to what do you know about it already? To what extent is this situation similar or different? So it's helping them to understand that. So if we think about the presentations of a patient with heart failure, not every single patient will present with the classical textbook description. It's like that student who said, when he heard the patient with the aortic murmur, this is syphilis. It's the fact that it could have been those other causes. So what made for this, it's not just listening to the murmur, it's all the context. He was correct about the murmur, but the problem is it's not just the murmur, it's the murmur within a particular situation or context. The context was that this was something like an 85-year-old lady. If she'd got syphilitic aortic valve disease, she would have never lived to that age because she'd have had other signs of tertiary syphilis. She'd have been dead by now, almost certainly. So the chances are, because she was elderly and she was in with, the chances are it would be atherosclerotic. So we need to start thinking about that. And that's the way of teaching it. So reflection, helping the learner to reflect, is absolutely important. But also it's important for the teacher. We need to reflect. How are we actually teaching and enhancing transfer of learning every time we open our mouths? Now, one of the things when people listen to a talk like this is, there's going to be people who find this really fascinating and they'll take everything on board. There's a group in between and a group who will think, well, this is really quite difficult to do. But just think about just some simple aspects you could do tomorrow, the next time you teach. Just think about it, just reflect. Am I actually making it relevant to the student? Am I teaching for conceptual knowledge? Am I checking? Am I assessing for conceptual knowledge? Am I providing a wide variety of different cases? Am I actually talking about what is similar and dissimilar about cases? Am I helping them that? We don't have to do all of them. I'm convinced that only one of them is better than none. And the more we do, the more efficient we are. And this comes to a concept called the theory of marginal gains. The Sky cycling team in Britain, this is what they did with Brailsford. He said that you only have to make little changes of lots of things for things to make a major difference. The same as in self-regulated learning. If you only get students to goal set, it is better than doing nothing. But if they can goal set and self-monitor, that's even better. You don't have to do everything to make it work. The main thing is to do something. And then as we begin to get into this, we develop our understanding, we start doing more and more and more. And that's how you and me develop our expertise in teaching for transfer.
Yes. Thank you. I think that we have another question.
Yes, that's okay.
One of the colleagues asked a question about what are the main different types of transfer and how we can facilitate each type. What are the implications of teaching for transfer for curriculum design and assessment? I think that you have covered the second, both parts of the question, but for more clarification, if you could add something.
Yeah. I mean, essentially, it depends on, if you want people to be able to transfer a simple task like CPR or suturing, and I fully understand, you know, with surgeons, please, if any of you teach surgery, please don't shoot me down. But, you know, suturing after a while is you know, it's a relatively simple skill. So if you're teaching suturing, you're going to have, you know, the depth of cut, the pressure that you put in and like that. Of course, there's the expertise with it, but if your simulation is only teaching that, you're going to be able to transfer that to virtually every single case at any time in the future. But the difficulty starts coming is if you've got a more complex surgical skill, like appendectomy. So one of my friends was a consultant surgeon, and there was a registrar who was fully experienced in doing the operations. And you can have this EPA idea, entrustable professional activity. My friend trusted this registrar to be doing operations by herself. And he got a phone call in the middle of the night from the doctor saying, I can't find the appendix. And he came in, and this particular patient had got a particularly long piece of bowel, which is of normal variant, and it was tucked at the back of it, but you couldn't find it. So what he said is, well, where is the appendix normally? Well, it's at the end of the small bowel where it meets the cecum. So he said, well, how do you know what's the small bowel? So if you found, oh, this is it. He said, well, which end is it? Where are you? So basically she had to work out from the peristalsis which bit was it, where it was moving down. So she wasn't going upwards towards the stomach. She was going downwards towards the cecum. And she just had to start moving through this long loop of small bowel. And there it was, the cecum. But, you know, it's using the basic conceptual knowledge. So if you want to be doing something like that, you need to be transferring that to different situations to the far. So if you were going to be teaching that, for example, in theatre, you could be, and you registrar that they're great, fantastic. You've really trained them to do the suturing. They're fantastic. They can do the gridiron. They can do everything. But to be saying, you know, sometimes it can be really difficult to find the appendix. So how would you do that? And you're actually talking about these scenarios. So saying things, well, if this was a 52-year-old man with a headache and not a 26-year-old man with a headache, would you manage the patient differently? And of course, you can build up this level of complexity. And that's part of the skill. What is similar or different by these scenarios. And part of it is, as we're teaching, we can be teaching for transfer all the time. And it's quite simple. So somebody's examining somebody, and the simple question is, well, if it was a 28-year-old man and not a 52-year-old man, what do you think of? somebody with abdominal pain. If this wasn't a 26-year-old man, and it was a 26-year-old woman, what would be similar or different? So it's getting people to be constantly thinking like that. And that, I think, is the skill of teaching. Because teaching facts is very easy, but it doesn't actually take very long, surprisingly. And you only need to do it occasionally.
Yes. We have another question, but let me provide the comments and then ask the question. The comment that it's so interesting to me because when you talk about the similarities and the different differences, I try to implement it in in your talk, and when I compared it, for example, with experience-based learning Spark model of Tim Dornan, and also community of practice, and found lots of similarities. For example, as you mentioned, the importance of support that help the learners to go forward for practicing and deliberation and about what they learned in new situations, and also about when you talk about the learner and environment, the importance of participation, as he mentioned in his model about the participation at different levels to improve the learning. But my major question is about, you talk about the importance of motivation, and the major focus of your talk about how we could improve the motivation was about the relevance, because I feel that a major issue for most of us is how we could motivate the students. Do you believe that rather than or other than relevance, there are some key points and issues that we could focus on them to improve the motivation of our students to learn, rather than just relevance and showing them the relevance?
Yeah, thank you, Zen. I mean, the problem is motivation it will depend on for the individual learner. At the moment, and I'm sure it's the same all over the world, because wherever I've spoken to colleagues, students tend to have what Carol Dweck calls this sort of narrow, restricted growth set, that they only learn things to get through the next exam. So they're not thinking necessarily about the long term. Now, for me, that is something to do with it's natural that students are concerned, they want to get through the exam, particularly, you know, the pressure of it. So if it's for teaching for transfer, I think it's about ensuring that what they're going to be learning in the exam.
I think, John, you're frozen. We can't hear you.
Can you hear me?
I could hear you, but I'm not sure that other colleagues could hear you.
It's loud.
Yeah, it was, I think, momentarily frozen. Are you there, John?
Yes. Yeah.
Yes,
I didn't.
yeah.
It didn't come up as that. I got a connection issue, so I'm sorry if it was. I didn't know. But anyhow, so I'm not sure what I was saying about the motivation. So it's about the type of mindset that they have. Carol Dweck talks about the growth mindset. You're learning for the sake of learning and for the future. Students tend to be obsessed about passing their next exam, and I fully understand that. And I think we have to accept that they are highly anxious about that. So what can we do? They don't want to read more. They don't want to do more because I want to know, if I do that, you're going to pass the exam. So that's great. Which then puts it down to us as educators to actually provide an exam where they can't just learn it, rote learning. there might be a rote learning component to it where it's just simple factual recall. But what they're going to need to do is there's two things. One is to write questions which are conceptual. Now, that is really difficult. However, if you're an expert on a topic, you should be able to think, what is really crucial that I want the learner to know. If they don't understand it, it's not just the facts, but what if they can't understand this concept, how are they going to manage it? So, for example, cardiac output is dependent on the stroke volume and the pulse rate, I believe. So they need to be able to understand that principle. So what you do, you would give questions which tests whether they actually understand. You're not saying, is stroke volume an aspect of cardiac output? You might give that, but what you're doing is that you start giving questions which are designed to seek whether the student understands it. So if the pulse rate goes up, what happens, and the stroke volume remains the same, what happens to the cardiac output? Does that kind of make sense? So I think one way of getting students to be motivated at an early stage is to say, well, you actually need to have this level of understanding. The way of also doing it is to give them present it as a clinical case. So it's a 58-year-old man. So you're getting them to be thinking immediately that this is clinical. Because then when they go on to the award or the year after the clinical years, they should be aware that they've got some conceptual understanding, but they've also built up this schema that this is about a 58-year-old man. And I think one of the advantages of problem-based learning, case-based learning, team-based learning is actually having the clinical component to begin with. I think it primes people and it builds up their clinical memory. But you can also give, the scenarios in a multiple choice, you can vary it very slightly. So one can be a man, one can be a woman, one could be a child, but they're all based on that conceptual understanding. So does that help? I think motivation is such a really difficult thing. Motivation depends on the individual. It depends on their relationship with you as the teacher, and it depends on the relationship of the learner within the institution, with other students, with everybody else. But also it's incredibly complex. I think it's, I think learners who are struggling to learn, which is a different issue, we really need to understand what is going on. We need a very holistic view of it.
Yes, thank you. We have lots of few comments that are aligned with the discussions. One of them is about the importance of assessment, and the way that we treat the assessment has direct impact, as you mentioned, on the learning of the student. And also some other colleagues talk about the importance of motivation and what should we do to them. But one of the colleagues, Dr. Perveen, asked me that I'm not sure that Dr. Perveen Delavery question has been answered during the session, and therefore I asked her to, Dr. Perveen Delavery asked about adult ADHD student. Is it same with others? I'm not sure. I
No.
remember that very early he asked a question about adult ADHD student. Do you have any comments about these specific type of students?
I don't. I think it's links to much wider neurodiversity. I mean, different people learn in different ways with different motivations. The work from working with neurodiversity, as far as I understand, is that the predominant approach that works is developing their metacognitive skills. And the metacognitive skill, because people do learn in different things. They tend to learn many. Part of ADH, I think it's all these are really complex. That there's a lot. If you're drawing a Venn diagram, as far as I understand, there's a whole spectrum of neurodiversity, and there's a lot of interrelation between them. There's an aspect of usually low concentration for all sorts of reasons in neurodiversity. There tends to be an over-reliance on minutiae of learning facts without necessarily developing conceptual understanding. There tends to be some degree of impulsivity. Then they need to learn it now and not thinking of the future, of their consequences. A lot of it is about helping students to slow this process down, recognizing that they have a way of dealing with learning and transfer, but also that they need to develop these essential metacognitive skills. So the metacognitive skills are very much about, when they approach something, is about thinking about, what do I need to do? How am I going to do that? How am I going to do this for transfer? What skills do I need? Does it work? Doesn't it work? And that part of the training, I'm not an expert in it. I think I'm not sure if it has answered the colleague's question, unfortunately, and I apologise if it hasn't. But I think I'm not specifically sure what the details or what the colleague wanted, unfortunately. But I hope my reply is useful in a general term.
Yeah. Thank you. I'm not sure how many times we have left for further discussion, but as might be the last question.
Yeah.
One of our colleagues asked a question about how we can measure the long-term impact of teaching for transfer learning on patient outcomes in the healthcare system. It's so similar to the previous questions from the same participant, how we can effectively measure the transfer of learning, especially when it occurs in complex and authentic contexts like clinical care setting.
Yeah. I mean, I think this is a bit of the holy grail, really. I mean, it's if you draw a logic diagram, you've got lots of surrogates, which you can easily measure, like prescribing, appropriate clinical reasoning, test ordering, things like that. But measuring patient outcomes, there are those which can be measured very, very easily, like surgical complication rates or burst wounds. A lot of these clinical outcome measures, unfortunately, are dependent on factors which have got nothing to do in complex situations with anything to do with your input as a doctor anyhow. They're dependent on much more societal factors. They're dependent on much more environmental factors. And I think the main thing is that there are some objective measures of what we consider to be good practice, good clinical outcomes. So we need to decide on that. For me, if you're a radiologist, you would assume that being able to appropriately interpret a radiograph is important. So you need to be able to measure that and go back. I think, and it's looking at what types of errors do people make. And that's, I think, where we can learn from, again, from our teaching, particularly in the clinical areas, where if we engage with our clinical colleagues, we can say, what are the common issues that junior doctors are missing? And then drill backwards to design the simulation. So we're doing some work at the moment with some anaesthetists about communication skills. So what we're looking at specifically are looking at patient care, looking at complaints, looking at instances of poor care. What communication difficulties have there been? So we're now deciding that we're going to plan training so that we can address that. So, you know, it is about working in this joined up system. If we want students to function well in the health system, we actually need to understand some of the difficulties where there is a breakdown in transfer of learning. Some of the outcomes, health outcomes, we're not going to be able to influence. It's totally impossible to influence because they're so highly complex. But some of them we can identify. And if we can identify them, things that were really annoying, you know, things which are commonly missed. And, you know, drill down, is there an educational aspect that we can offer to try and improve this? There may not be an educational one, but if there's an educational aspect, what is it?
John, you've gone to sleep. Can't see you. I see you, but you're frozen.
I'm sorry. Does everybody else frozen?
Not that it's on your side, sir. It's perfectly all right.
Yeah.
Probably the legacy issue.
Yeah.
Yes. Dear Shabih, it seems that it's for your system and for many of our colleagues, they could use the video and also the audio of the system of the webinar.
Yeah. Okay. So I hope that answered it. I think it's complex, but the main thing is that if we, you know, I think this is an area which, you know, if we feel is important, it's about collectively beginning to look at how can we actually enhance transfer. This for me is probably the greatest area which we need to be focusing on in medical education at this moment in time, because we're spending millions and millions on education. I don't know about, you know, other countries of the world, but certainly in the UK, we want to train doctors in the shortest period of time. We want to reduce medical school training down by a year. People are talking about even doing part-time medicine so that you do a medical course over maybe 8 years, part-time. These are going to be incredible challenges. And the biggest challenge is, you know, if you're going to be redesigning the courses, we've got to redesign. It's increasingly difficult to get clinical experience in hospitals, certainly in the UK, because there's a big throughput of patients. Patients, you know, they're not in hospital for days. You know, they're coming up as a day case and they're out again. They're being managed very quickly. So all these things are really, really important. There's less time for teaching. Nobody seems to have the time for teaching. So, you know, we're going to have to move quickly. And for me, transfer of learning is this, you need to see lots and lots of people, but seeing lots and lots of people is no guarantee that you will get transfer of learning. What you need is some structure to help you by seeing lots and lots and lots of people. That's how experts develop. They see lots and lots and lots of people. lots and lots of cases. But it needs to be more than just seeing lots and lots of cases. And the problem is we haven't got the time to develop expertise over 10, 20 years. We've got to compress it. So how can we do that? You can still see lots and lots of cases. So we're going to have to rely on the use of technology, virtual patients, quizzes, adaptive testing. We're going to need to be able to identify learners through formative assessment. Are they on the right track? Aren't they on the right track? The majority of students will have the intellectual capacity to transfer rapidly. The difficulty and to learn, the difficulty is this 10% of students, which many people have identified, who struggle. And they're the group that we need to be able to focus on, because they are going to struggle during these much more compressed approaches for teaching and learning. And that's our
thank you so much.
I think it's time. Thank you so much.
Okay.
The wonderful presentation by Professor John Saunders, and thank you so much, Dr. Azim Mirzazadeh, for moderating the session. Over to you, Professor Shabih Mirzazadeh, for some last words.
Well, thank you, Professor. I'll just switch on myself. Thank you, John, for a wonderful talk as always. I think what I gathered is that as we were talking earlier before the session, that the experiential learning. You have the concept, you have the prior knowledge, but more important is a combination of prior knowledge with learning experience, so experiential learning. And that should be concept-based, but also context-based. And I think time has come when we start talking about phenomenology, like I mentioned to you. And perhaps you and I can, and anybody else who's willing to join, we can have a podcast sometime during the year on the role of phenomenology in medical education. Please let me know, anybody who's interested. Otherwise, I'll invite John and Azim to have a podcast and we can discuss these technical things. Also, we need to discuss about this new concept called micro-learning, which fascinates me. Azim, maybe you can also join that. So these are things, and Azim, grateful to you for moderating.
Thank you.
John, thank you so much for enlightening us yet again. Please come back sooner than November. We have one session for you in November, but before that, if you can find time, we can do podcasts.
Okay. Or I'll do the November one on phenomenology. It's a fascinating area. It links into, as we said earlier, it very much links into reflection and Dewey and so it was. I've got the books on it and I've read heavily because I did counselling training years ago, and a lot of that it links to counselling, people's belief systems. So it's a fascinating area.
Right. Well, thank you again, and have a good one. Most grateful to all who joined today.
Yes,
and
thank you,
this recording will be available soon. Thank you, Azim. You have to come back and do a workshop for us soon.
Thank you, Tom.
Yes, thank you.
Thank
nice
you.
to meet you
Thank
again.
you so much.
God bless you all.
As well. Thank you. Best wishes
Thank
to
you
everyone.
To everybody.
Thank you.
Bye-bye.
For all those who want, thank you, sir. All those who want a certificate of this particular session, please register at webinar.alsadikuni.com so that you can get the certificate of attendance. Thank you all. Take care. Goodbye.
Thank you very much indeed. Bye-bye.